Thank you very much, Dr. Hanel, for the invitation. So you have seen some of this before. Um, so the idea here is to kind of focus on the system that enables us to get to the CP angle cistern. And as we mentioned, the delivery catheter that we built to deliver the e-shunt actually gets us into the CP angle cistern, which means we're actually right next to the brainstem to enable us to inject different agents. And so this is, again, the kind of privileged position that the system puts you on right in front of the brainstem at the CP angle cistern. Just reviewing, we use this anchor to get us up there. And at this point, this is where we stop. Instead of delivering the device, we actually use the needle potentially to withdraw some CSF and then actually introduce a pharmacological agent. So I'm just going to zip through that again, just to summarize the procedure, going through the femoral vein. This is the jugular vein, and then we go up into the inferior petrosal sinus with our microcatheter. We use that to deploy the anchor, which is a temporary device. This is the system coming up over the flat rail with the needle guard. The needle guard is going to be retracted here. And once we're in position, we basically are able to traverse into the CP angle cistern. At this point, at the end, we actually are able to pull back. And so we're all done, obviously, in this case, for the e-shunt delivery. We talked about the protection mechanism to enable the penetration not be too deep. This is what it looks like when you just have the needle in position. The flat trail, this is a cone beam CT showing the flat trail going up to the cavernous sinus. And this is basically what we are aiming for, access into the CP angle cistern. And it turns out that the velocity of the CSF flow is actually quite a complex model. You can actually spend a lot of time trying to model it, and it actually is dependent on whether you have any spinal pathology, if you have discs or any kind of spinal stenosis that actually can affect CSF flow pattern. And so for a lot of the typical drug delivery that may be done through a lumbar puncture, there are basically limitations to that approach that may not be so prominent when you actually deliver a drug near the cisterna magna or the subcerebellopontine angle cistern. So the idea, again, in a single delivery would be to go and traverse and then administer, for instance, to the gene delivery or a vector in single time, and then come out. The dura is self-sealing. It provides access to the cerebellopontine angle cistern, and eventually it may be possible to deliver that through a brachial, axillary, or cephalic approach, or using subclavian vein or a jugular vein. So what are the common methods of drug delivery right now? The most common one is via an Ommaya reservoir. It's basically inherently invasive because you have to make a burr hole, advance a catheter in the ventricle and go through brain. And of course, there's a repeated injection that can be fraught with risk of infection. The other one that is very popular in gene delivery is the cisterna magna injection. This is done on a lot of kind of non-human primates to demonstrate the effectiveness of gene delivery. Unfortunately, it's a lost art for doing it in humans. I don't know if any of our hospitals have an old-timer radiologist that can still do this safely. But again, that's one that a lot of pharmaceutical companies are espousing. There's, of course, the lumbar puncture technique. The problem with it is the distribution is variable. And then there are cervical injections, which again, is a bit higher risk, and there are fewer operators that can do it routinely. We think that using patient-based image guidance to help us determine the ability to access the CP angle cistern, and being able to use it in a single time fashion, would basically enable us to achieve this result. What if you need kind of a repeated drug delivery? Well, it is possible to have a e-shunt equivalent device, if you will, but instead of having a drain CSF, it can actually be connected to a port or reservoir that's subclavian that can then have multiple infusions. You would think potentially if something like this, either perhaps not with a port, but going externally, temporary device for treating vasospasm potentially, or other diseases that may require repeated injections, or for potential chemotherapy. So the CNS drug delivery challenge is that you have to go across the blood-brain barrier, and this is kind of one of the major obstacles for successful drug delivery. And so you can do it intravenously. Unfortunately, you have to use high doses, and the toxicity for the systemic system obviously is going to be high. You can use a lumbar injection, but again, the amount that actually will get to the brain is unclear and very low. You can use an interventricular approach and or cisterna magna approach. So if you look at the kind of this plot between invasiveness on the y-axis and biodistribution on the x-axis, you see that you go all the way from intravenous, let's say if you're using an AAV and an associated virus, the invasive is low, but so is the biodistribution. If you go directly into the brain, you have localized distribution, but also highly invasive. And you're really looking for something that is less invasive, but gives you the best biodistribution possible. This is a comparison of high dose cisterna magna versus lumbar puncture of AAV by the Stephen Gray's group. And what you see is if you look at the lumbar puncture, is significantly lower actual signal than when you compare it to cisterna magna, which is much closer to the brainstem. And so this is what you're trying to achieve ideally, is to achieve a much higher signal around the brain area and less systemically. And the cisterna magna approach, as you can see here at the top panel compared to the lumbar puncture, gives you a whole lot more signal near the brain, the brainstem. Of course, this is an old picture showing how the cisterna magna is performed, and it's going to be difficult potentially to have it used widely in a clinical setting for any of these gene therapies that may come to market. This is another study, again, comparing the cisterna magna as being superior to both lumbar and IV. So we're trying to kind of achieve the same result at the cisterna magna injection, but be more controlled and less invasive. This is a very nice study by Matt Guinness' group and Heather Gray at UMass, where they actually demonstrate going from a lumbar approach in the sheep model with a microcatheter all the way up to the cisterna magna for delivering a gene therapy. And so we actually set out to see if we can get to the cerebellopontine angle cistern using the same sheep model with a microcatheter technique. And a lot of this work and the whole concept of traveling from a lumbar puncture was previously described or espoused by Phil Purdy. This is kind of where we started. And you can see we're just starting with a lumbar puncture in the sheep model. This is an SL10 microcatheter with a synchro microwire. We're now in the thoracic region, and then actually we're able to consistently get to the cerebellopontine angle cistern, which is the same site as the e-shunt drug delivery system would be able to get us to. You can actually see the contrast injection, and this is the 3D reconstruction of the sheep showing that the microcatheter at this level. So we've been working with Dr. Gunes and Vanya at UMass to actually see if we can reproduce the results that they obtained with cisterna magna injection when using this with the cerebral pontine angle cistern injection to see if this would be a viable approach for gene therapy that is kind of potentially less daunting than the cisterna magna approach. So what's next? It is also possible to use this approach for going further as the imaging that you saw with the high frequency OCT becomes possible. You can envision using the IPS access to actually navigate through the subarachnoid space and then potentially reach the third ventricle or the lateral ventricle for drug delivery at this point, or potentially even for treatment of obstructive hydrocephalus if we can achieve that safely, potential with a small balloon, effectively performing a third ventricular EVT from below. And that's kind of where we are, and some thoughts about the future when it comes to using this platform for drug delivery. So in conclusion, the CERVASC cisternal access system provides a minimally invasive approach to the central nervous system for gene therapy. It can be both used in a single or multiple infusion sessions, and also provides an approach for reaching other parts of the ventricular system in the future. And we are currently awaiting the results of gene therapy injection in that region to compare to the gold standard of the cisterna magna. And thank you very much. Thanks.
Thank you, Adam. Can you illustrate to the crowd what pathologies you're talking about when you talk about gene therapy and drug delivery, specifically which pathologies you're talking about?
Sure. I think, a number of movement disorder, a number of neurodegenerative disorders, something like Tay-Sachs disease, which actually has been treated by the UMass group using this small catheter. All of these rare diseases where it is possible to augment or replace a gene, a single gene with an adenovirus approach. It also opens the opportunity for treatment with stem cell therapy. It also offers the opportunity for treatment of tumors, potentially drug mets with medulloblastoma and others. So I think it's a way to, anything that we would treat with an Amaya reservoir potentially could one day potentially be approached with this minimally invasive kind of percutaneous approach. That's the hope.
Adele, fantastic talk. Can I ask a question?
Thank you very much.
Phenomenal work. Thank you, man.